Welcome to the Alex Salmond Show from Strichen, Aberdeenshire, where we continue our examination of the subject which has consumed the planet over this year. That is, novel coronavirus and the spread of COVID-19. Today on the show we speak to two international experts, each in their own way, on the front line of fighting this pandemic. First, Professor Hugh Montgomery, the international expert on intensive care. And then to Dr. Chris Smith of Cambridge University, someone who on this show in early February warned in no uncertain terms about the scale of the threat emerging from the East.
What you've potentially got is something which, while it's less lethal than SARS, is much more infectious than SARS and about as lethal as the 1918 flu pandemic, and everyone's susceptible to this, like they were for the 1918 Spanish flu pandemic. So if this were allowed to escape and go to its logical conclusion, one possibility, one worst case scenario, is it could be as bad as 1918.
So therefore, why weren't the alarm bells ringing for policymakers across the Western world? I will ask Chris Smith that very question later in this programme. But first to Tasmina, with your tweets, your messages and your emails.
We've had a fantastic response to last week's show, and first we hear from Mike from Seattle, who says, "Greetings. Enjoyed your insightful analysis today on the show. Gratitude and solidarity with you in this weary, despondent time." Then we hear from Shirley, who says, "Clear explanation by Dr. Honigsbaum as to why we went wrong re COVID-19, and good to see a plan out from Dr. Fabry from Malta. Maybe the Scottish Government has one it made earlier, ready to go for it, as advised by Professor Blanchflower." Jan says, "It's been so disappointing to see us follow the Tory lead, which has been bumbling and inept at best. We're in a well-being collaboration with New Zealand and Iceland. Both are doing way better than us. Why are we not drawing on their experiences and successes? Why are we not leading the way in the UK?" David says, "The thing about making herd immunity work is that the disease requires between 8 to 10 waves before it can work. In the meantime, many people die, and we're talking a lot of numbers. This disease is going nowhere, and a vaccine is a long way off." John says, "The government are clearly imposing the lockdown in more palatable 3-week chunks, when the reality is that this will continue for longer than that. Scots need to be responsible, patient and calm, while accepting this short-term disruption for our longer-term well-being." Margaret says, "Great show, Alex. So refreshing to see questions that are honest and enlightening and that can be responded to honestly." Sonia said, "Look forward to visiting Malta again, probably next year now, as Malta closed the day before our flight. Take care, everyone." Donald says, "Brilliant show, Alex and team, very thought-provoking. A universal income now would help those that are struggling." Norma says, "Best half hour of the week, Alex. Can't you do one every day to help us? Always very interesting." Thanks, Norma. David says, "Cuckoos in the Scottish Parliament stop life getting better in Scotland. Born in Scotland they may have been, but patriots they are not." And finally, Lorna says, "Really good to have this discussion. Nobody's talking about the possible exit and the economy."
Professor Hugh Montgomery of University College London was one of the first experts to explain clearly the dramatic difference in infectivity between coronavirus and normal seasonal flu. Seasonal flu, if you allowed the infection interrupted at a factor of 10 times removed, can infect perhaps 14 people in terms of one case. The relevant figure, the comparable figure for coronavirus is 57,000. That's how infectious this new disease is. I spoke to Hugh Montgomery from the front line of fighting this disease in West London. Professor Montgomery, you're one of the people who's managed to explain the difference between an infectivity factor of 1.3 and an infectivity factor of perhaps 3, as in the case of coronavirus. Could you just explain what difference that makes to the number of people who can be infected by a single case?
Yes, indeed. And of course, this is the big issue. It's not the fact that everyone who gets this disease becomes critically unwell and dies. Far from it. I mean, it's probably between 50 and 80% of people who get this disease probably don't even know they've had it or get very mild symptoms. It's the remaining group that become profoundly unwell. And it's a question of numbers. So an ordinary flu, which comes around seasonally every year, every person will infect on average somewhere around 1.3 people, if there were such a number, which means that by the time you get to the 9th or 10th generation of people passing that on, each one person passing it on to that sort of number, in total, when you get to the 9th pass, you're passing it on to maybe 15 or 20 people, and in total, maybe around 60 people have been infected. If this virus behaves as it does, which is highly infective, infecting north of 3 people per person, by the time you get to that 9th transmission, that wave is transmitting to 59,000 people, and in total, over 100,000 people have been infected. And so you can see that even if only, let's say, 1 in 200 of those dies, it's still a very, very large number indeed. And this is really why the only solution to allow the health service to cope has been to limit transmission, because there is no specific treatment for this. Everyone hears about chloroquine and other drugs. There isn't a proof yet. The trials are ongoing. So currently we don't have a magic bullet to treat this. All we can do is take patients who are dying, otherwise put them on an intensive care unit and support them as best we can to allow their bodies to recover, which they do in roughly 50% of the cases that we're now admitting.
And has there been lessons learned on relatively simple techniques of treatment, even the posture of the patients as they're in intensive care, I understand, can be quite significant?
Part of the problem why there's very low oxygen levels in the blood is because the blood supply in the lung is often going to areas of lung where there isn't very much oxygen because the lung tissue is badly affected, or the areas that have got good oxygen supply coming in from the outside don't have much blood supply. And that's known as ventilation and perfusion mismatch. You're giving blood to the wrong bits of the lung. And for various reasons, you can improve that to a degree by lying the patient on their tummy. And we found that actually we can do that very early on. So patients coming in with low oxygen levels now, even on arrival in the emergency department and on the wards, we're suggesting to these patients that they lie on their chests, essentially, in a sort of modified swimmer's position, so one arm above the head, one arm down by the side, and they do that for as long as they can tolerate. And that does seem to improve oxygenation and allow us to get away with less aggressive treatments at that time. Once people are put on ventilators or machines that do the breathing for them on intensive care, pretty much all of them are now needing to lie in this prone position for between 16 and 18 hours of each day. That has its own problems. It's not the healthiest thing. Pressures in eyes become a problem, pressure on faces, and it's not a comfortable position. So these patients are paralyzed with drugs and heavily sedated. And it's very hard to get them to improve. So a lot of our patients are still spending 16 to 18 hours of the day in this prone position, even after 2 weeks on our intensive care units.
Now, thanks to the heroic efforts of yourself and your colleagues, the National Health Service has not been overwhelmed in the way that many people feared at the start of this outbreak. However, how is the situation with protective equipment, which has been well reported as a major scandal, that the people are being sent into the front line without the proper equipment? How is that? Has that been resolved as yet, Professor Montgomery?
Well, it hasn't as yet. And of course, this is... it's fair to say that the NHS has managed to cope thus far, but it's largely been due to the heroic efforts of the British public, to be honest, the fact they've taken the lockdown so seriously. That has flattened the wave, as they say, turned a tsunami into a much longer, slower roller. But the burn rate on materials and resources has been huge. So most hospitals are in trouble with the numbers of pumps they have. We're running out of the filtration units, the things that are used for kidney support when kidneys fail, and indeed for the fluids. We're running short of the sedatives and anesthetics and paralyzing agents. And this isn't just Britain, this is worldwide. Every country is facing this sort of challenge because the production and supply and distribution of these drugs wasn't geared for an event such as this, and it takes time to ramp up. So it is a real challenge. We are beginning to try to work out even today how we're going to get around this. Is it possible to wash and clean equipment, to use different sorts of clothing and so forth? But that itself can have challenges. One of the ways in which this bug is most readily spread is in actually taking off the clothing, where just the act of shaking the fabric can release the virus. So we're going to have to develop new patterns of working if we are going to start reusing this protective equipment, which I suspect that we are.
Professor Montgomery, the key emphasis has to be on public health at the present moment, and the organisation to stop the spread of the virus until such time as there is a drug therapy available which can make a crucial difference.
Yes, or indeed, in fact, until there's a vaccine, because until there is a vaccine, this disease will continue to spread and will infect pretty much everybody that hasn't had the disease until we get up to this thing called herd immunity, where there's enough people to make transmission between patients or between members of the public very much harder. So this is going to continue to spread until a vaccine appears or until the bulk of people in the population have contracted the disease. And the only way, as we say, that we can cope with this is to shield the most vulnerable until a large number of the public have been infected and the disease is therefore harder to transmit, but also such that there are a trickle of patients coming in a more continuous fashion rather than a tsunami of patients hitting us, in which case the health service can't cope. And this is going to be a real challenge to any politician anywhere in the world. And we've seen this in Japan. It managed to lock down very hard, aggressively suppress transmission of cases. But now, because there isn't very much herd immunity, it's coming back in massive force. And this will apply to any country that's managed to suppress the virus. When they lift the foot off the brake, it will spread like brush fire again. So the trick, until we get a vaccine, will be to try to take one's foot off the brake sufficiently to allow people to contract the disease, but not in such numbers that the health service in that country can't cope.
But then, of course, it's only 5 weeks since in the UK they were holding the Cheltenham Festival with 100,000 people grouped together, and or the Six Nations Rugby with 20,000 French supporters across Edinburgh. Aren't
Yes.
there rather obvious things from what we've learned about the infectivity of this condition, which at least would stop that sort of event taking place for the foreseeable future?
Well, indeed, and of course, it is worth pointing out that the social isolation has worked, but the distancing measures, even when people are together, make a massive difference. So when I'm in the hospital, obviously I have to work with colleagues, and outside we're not wearing PPE. It's what we're wearing, the personal protective equipment is when we're in the red zone with patients. But we maintain a 2-meter distance from each other. We don't pass each other on stairwells. When we're doing handovers, the chairs are positioned to be 2 meters apart from one another. We wash our hands regularly and frequently. Whenever I see an alcohol gel bottle or a sink, I'm washing my hands. And by doing that, it makes infection exceedingly difficult to contract. So the incidence in my own hospital has been very, very low indeed. And this applies to the general public. If they do, once the lockdown is lifted a bit, if they do maintain that 2-meter distance, if they do continue not to shake hands, if they do wear masks not for themselves but to prevent coughing and transmitting to other people in an asymptomatic phase, and if they wash their hands regularly all the time, because whatever they touch may have been infected, and if they themselves are asymptomatic, they can be spreading the disease that way, that in itself makes an enormous difference.
Professor Montgomery, and finally, with the experience you've had on the front line, married to your vast academic expertise in this subject, if you had one lesson to deliver to policymakers around the world, given the experience of this vicious condition, what would that be in terms of how they develop their policy?
We've got to put this, I think, in a much broader context of the way in which we're treating our planet. If we chop down rainforests, decide that we're going to eat exotic meats, and kettle together everything from snakes, bats, and pangolins with chickens and dogs in market spaces, and then everyone thinks it's their right to fly around the world as often as they like wherever they go, then there is no hope for us, because this will continue. We have to start recognizing that the planet is itself vulnerable, that we are biological organisms as part of an ecosystem on it. We need to reconsider completely the way in which agriculture operates, trade, the way in which we manage our natural resources, and the way in which we travel. Because these sorts of behaviors have brought us to this point, and they will continue to do so again. So the world needs to rethink how it behaves, and also to learn to behave a great deal more cooperatively, as we are learning to do now, unfortunately, in these sad times, a great deal more cooperation than there has been before. And we need to make friends, not enemies.
Professor Montgomery from West London, thank you very much, and good wishes to you and your colleagues.
Thank you very much, and thanks for having me.
Coming up after the break, I will speak to Dr. Chris Smith, the Cambridge virologist who runs the Naked Scientist podcast. Welcome back. At the beginning of February, I interviewed Dr. Chris Smith, the virologist from Cambridge University, who forecast very clearly the extent of the coming fury. Today he joins me from the village of Barrington, just a few miles outside Cambridge. Dr. Chris Smith, from the information we have to date, both in this country and of course internationally, what has surprised you about the nature of this virus?
The speed with which it appeared and then spread through society, and the impact it's had. You know, I've been giving lectures for more than a decade on emerging infections. These are infections that are newly appearing in the human race or used to be confined to one small geography and have suddenly started to extend and spread across a bigger range. And so I was fairly familiar with what could happen, but it's even taken me by surprise, you know, the scale of this, the economic impact of this, and the psychological impact of this. I never knew what it could be like to be confined to my living room, and now I'm finding out, and I don't like it.
How close, in your estimation, are we towards a drug therapy which can make a difference?
Well, drugs take a long time to make, especially new ones. And the current estimate is you're looking at about 10 years and 10 billion. And I don't mean 10 billion tries, I mean $10 billion in some cases. And if you ask most people in charge of pharmaceutical companies, they will tell you that 90% of their ideas fail. So they've got about a 10% success rate. So it's a rule of tens here. And so it's not exactly easy to deliver a new agent with a new drug against a new virus we've known about for just a matter of months. This is a very tall order. It's not impossible, but a very tall order. So what people are doing instead is they're saying, well, are there any drugs that we already have which we could repurpose? Now, the basis of this is that all drugs have side effects. And sometimes, just by chance, you find that a drug that you made to treat a totally different condition, just by chance happens to hit this new infection or this other disease and cure it as a side effect. This is called repurposing, because if you can take a drug that's already on the market, it's already been through safety trials, we already know how it performs, we know how to handle it safely, it's much faster to take that existing drug and create a new use for it. And that's exactly what doctors and scientists are trying to do with this new coronavirus outbreak. They're exploring a number of avenues. But again, these things do take time, and they're not guaranteed to work. It's not like you're tailor-making an agent like you would with a new drug. So all cards are on the table. No cards are off the table.
And are you and your colleagues at Cambridge part of that effort? And is it a genuinely international effort to find that sort of treatment?
Yes, both. What's amazing is the way that this has galvanized and brought together the scientific community. People are sharing data. The deluge of publications and information and science coming out every day is impossible to keep up with. There's so much of it. And the whole collaborative feeling of people working together to try and find a solution, it's really heartening, really heartwarming, and really exciting. And at Cambridge University, many universities are doing this, but I'm really reassured and buoyed up by the fact that they've taken one of the biggest departments in the university and one of the most powerful, with a really big headcount, and basically repurposed what that department's going to do and made its main focus dealing with the coronavirus. And that means dealing with understanding how it makes people unwell. It means dealing with understanding how to treat it better, with possibly finding new drugs, and also possibly pursuing vaccines as well. So there's some really bright people from across a range of different disciplines all working on this. And it's really amazing to see how universities are able to, in this very agile way, change their focus to deal with this. So I'm kind of reassured, because we've got some amazing scientists in this country and some amazing doctors. And so we're really well placed with some of the best universities as well to take this on. And I think it's really bringing people together.
Now, despite the amazing scientific base and the extraordinary efforts of those in the National Health Service, the death rate in the United Kingdom per head of population is 5 times that of Germany and 50 times that of South Korea. Do these differences all lie in the realm of public health and how they intercepted the virus, or are there any other explanations, for example, in genetic or population factors?
no cards are off the table. People are investigating and pursuing this actively. You've got to be careful, though, with any kind of comparison that you're really comparing apples with apples. And this is one of the frustrations. Various countries are testing various people in various different ways, in various amounts, and generating data. And it's very easy to say, well, this is what Germany have done, and this is what Korea have done, and this is what Britain have done. You must make sure that the denominator is the same. Germany haven't tested the same spectrum of their population that we have, for example. So Germany acknowledged that they have tested a very large number of young, healthy, fit people, a significant component of which were downhill skiers. There are not many older people who are with multiple health problems going downhill skiing. Perhaps a few, but not many. So if you go and test lots of people who are otherwise fit and healthy and they're low risk, you're going to report an artificially low rate of death. What we do need is testing to find out who's immune, and this is what's coming next. It's proved a bit of a frustration for the government, I think, because it's a very new virus. It's very hard to make really good tests that work reliably and work at the kind of level and scale that we're going to need. But that will be very valuable, because then we'll be able to tell people who is and who isn't immune, and then we can begin to decide who can safely go to work and work with patients, or work with, say, older, more vulnerable people who at the moment might be reliant on a carer to bring them shopping or to take care of their day-to-day needs. And that carer could also bring them coronavirus, whereas if that carer is known to be immune, then that carer won't bring them coronavirus. So it could be that we can use a test like that to help people and keep people safe, while also exploring other avenues, such as a natural herd immunity approach to ending this lockdown.
Dr. Smith, I put you on the spot in February, and unfortunately for your forecast was all too correct in terms of the dangers of this virus. Can I put you on the spot again? What do you anticipate happening as regards the drug therapies and treatments that may ride to our rescue? When do you think, given the knowledge we have at the present moment, these will become viable and emerge to come to humanity's rescue?
In terms of a vaccine, it would be wonderful if we had a vaccine that we could very quickly produce at scale. And by scale, we're talking billions of people are going to need to be vaccinated if we're going to stop this thing. And we need a vaccine that will work quickly and a vaccine that will be very safe. That is an incredibly tall order to produce in a matter of months. And people who are suggesting we'll have one by the autumn, well, I really hope they're right. But talking to the vaccine experts and virologists that I've been discussing this with, they are not optimistic, and neither am I. They're talking about at least 18 months, maybe longer. And to produce something at that sort of scale is a really, really tall order. So what's the plan B? Well, I have a very sneaky suspicion that what we're going to have to do is some kind of staged de-escalation of this lockdown, which is going to be informed by understanding where the virus has circulated most in the country, where it continues to circulate most in the country, and this will be informed by testing both for antibodies showing who's immune and who isn't, and who's currently got the virus. And I suspect that what we'll do is come up with a way of driving a degree of natural herd immunity while safeguarding and shielding those people who are most at risk in society, so that we arrive at an endpoint where we have enough people who are immune to stop the virus circulating appreciably, or treat people without the need for enormous amounts of PPE, or go and look after elderly people and care home residents so we're not putting them at risk, but we can at least drive that immunity we all need, because I just can't see us getting out of this anytime soon if we don't resort to some strategy like that. I don't think anyone can foresee it being possible to do multiple lockdowns and then reductions in lockdowns, because all you'll get is a boom and bust situation, as we're seeing with other places like Hong Kong and Singapore. And I don't think that unpredictability is any better for people than the present situation. The economy certainly wouldn't take that.
Dr. Chris Smith from Cambridge, thank you very much indeed, and best wishes to you and your colleagues.
Thank you very much. Thanks for having me.
It is said that the global flu pandemic of a century ago, the so-called Spanish flu, actually got very little coverage at the time. One theory is that despite killing up to 50 million people, it was difficult for people to rationalise the deaths of so many fit young people in the aftermath of the killing fields of the First World War. Nowadays things are entirely different. Thanks to 24-hour modern media, the new killer virus was well known about to virtually everyone, even before it emerged from Wuhan province in China. Thus, there is no policymaker on the planet who can claim an alibi of lack of knowledge or information about the coming fury. And faced with that challenge, it should be said that a number of governments, East and West, rose to the challenge, and the results are very clear to see. South Korea, Taiwan, Germany, New Zealand, Malta, Iceland, the Faroe Islands. Each of these countries and each of these governments have, in their own ways, managed to keep the killer virus at bay. And they haven't employed rocket science. They've all followed, in terms of their own circumstances, the World Health Organization advice to test, trace, and as a result, have managed to suppress the killer virus. No doubt they'll continue to try and do so until such time as a vaccine or a therapeutic treatment rides to humanity's rescue. Other administrations have failed and failed utterly. It's perhaps the case that Italy was overwhelmed before the virus was clearly understood. But there's no excuse for the governments of Belgium, of France, of Spain, of the United Kingdom, and above all, perhaps the United States. Each of these administrations failed to act until the virus was spread throughout their communities, and the high casualty rate, the death rate among their populations, is the result. That is not to decry or underrate in any way those in the front line in all of these countries, the people in the health service, the caring professions, who are making superhuman efforts to stem the killer tide. But to continue in the First World War analogy, these people are the lions who are being led by donkeys. It is to be hoped now that these same governments, having failed to stop the spread of the pandemic, but all of whom possess extraordinary resources, will now dedicate these to planning a rational way out of the grip of the virus. It will also fund their scientific base and the international effort required to find a vaccine or a therapeutic treatment. And above all, perhaps, will understand that there are many countless millions across this planet whose governments neither have the resources, even if they had the resolve, to tackle the virus effectively. It's only through that collective effort that we'll avoid countless millions dying of coronavirus in 2020. And so from Tasmina, myself, and the rest of the team, it's goodbye for now, and we'll see you next week.